great pleasure and honor to introduce my dear friend, brother, colleague, and the master of teaching cardiology all over the world. Dr. Ahmed Mohsen has the largest platform on the social media, including Twitter, Facebook, YouTube, for teaching cardiology to Egyptians and non-Egyptians all across the world. Dr. Ahmed Mohsen will elegantly represent to us a surprising case, actually fully managed from the clinical suspicion until the imaging and the final management. Dr. Ahmed Mohsen, I will stop sharing my slides. You can start sharing your slides, and I'm very interested to learn from you tonight, inshallah.
Thank you so much, dear Dr. Muhammad, for the kind introduction. I will share my screen now.
Do you see the share screen button, the green one?
Yes, yes.
Okay.
Can you see my presentation?
Yes, Dr. Ahmed, it's available. Thank you so much.
Okay, so thank you so much. So we will start our presentation today. The title for this presentation is From Uncertainty to Clarity, a clinical case study journey. This is a 32-year-old man not known to be diabetic or hypertensive, chronic smoker for 10 years. He smokes 10 cigarettes per day, and he presented first for another physician with retrosternal chest pain that has been started 1 week prior to presentation. The pain was dull aching, retrosternal, not radiating, continuous, not related to effort, and stationary course over a week. The patient sought medical advice in a private clinic, and the ECG was done as shown in the next slides. Actually, this is the first ECG that was done in a private clinic. Anyone from the floor or from the audience has a comment on this ECG? Any strange finding in this ECG before proceeding for the next investigations? You can write a comment in the chat if you like. Okay, I can answer this. This is the first ECG that was done, and if you look for EVR, you will notice that the EVR lead has a mainly positive QRS. So in this case, you should suspect a limb lead reversal. So the ECG was repeated, and now we can see that the EVR lead has the usual shape with negative QRS and the negative T wave. And you can notice that there is evidence of possible ischemia. You can appreciate the presence of pathological Q waves in the inferior leads, and the heart rate looks rapid. Apparently, the patient has sinus tachycardia. These are the two ECGs, the first one with the limb lead reversal and the second one after correction of the limb lead reversal. The treating physician actually treated this patient as sinus tachycardia, and he prescribed beta blocker. Then the patient presented for me after about 1 week, and he told me that there is no improvement at all in his symptoms. I asked him, do you have any palpitation during this week? The answer was no, he didn't have any palpitation. When I looked again for the ECG, I have noticed that the speed of the ECG recording was incorrect in both ECGs. The speed was 12.5 millimeter, half speed. The standard speed is 25, as you know. And this half speed give you a false impression or a false result of apparent tachycardia. It doubles the actual heart rate. So actually, the two ECGs were wrong. And this is the first time to see two mistakes in a single ECG. Wrong calibration of the voltage and wrong placement of the leads. Together with evidence of pathological Q waves in the inferior leads, which was very strange for me. The patient is relatively young, and the pain description was totally atypical. So the patient was diagnosed as sinus tachycardia based on the previous ECG and was prescribed beta blocker to control his heart rate. The patient then presented to me to ask for a second opinion. By obtaining adequate histories, there was no history of palpitation or dizziness or syncope, no history of pulmonary congestion, systemic congestion, or low cardiac output, no history of constitutional or pressure symptoms, no history of systemic or pulmonary embolic symptoms, and no family history of sudden cardiac death or premature coronary artery disease. As regard the physical examination, vital signs, heart rate was 75 beat per minute, regular average volume, blood pressure 130/80, temperature 37, and respiratory rate 16. The head and neck examination was normal, chest examination normal, abdominal examination as well, and normal examination of the extremities. What about the local cardiac examination? The apex was felt in the sixth space just outside the left mid-clavicular line, which may denote possible left ventricular dilatation, localized with systolic bulge and normal character with no palpable thrill, no other visible or palpable pulsation, normal heart sounds, and no additional sounds, with short, soft systolic murmur over the apex, grade 2/6, suggestive of possible mitral regurgitation. So I repeated the ECG with the standard settings, standard voltage calibration, and the standard speed. Now you can notice that the heart rate is not rapid. The heart rate is about 75, and there is evidence of pathological Q waves in the inferior leads as a persistent finding with poor R wave progression in V4. So we have a possible signs of ischemia. Then I performed this echocardiogram, which showed a clear evidence of bi-leaflet mitral valve prolapse with thickening and myxomatous degeneration of both leaflets. And you can notice that there is evidence of mitral annular disjunction as well. The posterior mitral annulus is detached from the posterior left ventricular wall. And it is very important to be aware with or to appear aware with the criteria for diagnosis of mitral valve prolapse in echocardiography. As you know, mitral valve prolapse is over-diagnosed in many cases, and we should stick to the criteria for diagnosis. Look for this image. The yellow line represents the level of mitral annulus. And the pink line represents the degree of posterior displacement of both leaflets behind the level of the annulus. This distance should be at least 2 millimeters to diagnose mitral valve prolapse. And here we can notice the evidence of mitral annular disjunction. The posterior mitral annulus is detached from the posterior left ventricular wall with a clear distance between both. And this is a very nice demonstration for the mitral valve prolapse in M mode. And this is a demonstration for the MAD, mitral annular disjunction. We measure the distance between the posterior mitral leaflet and the posterior left ventricular wall. And here the distance was about 9 millimeters. Mitral annular disjunction can be also appreciated in M mode. Very clear thinning out of the posterior wall during systole. This is a characteristic for mitral annular disjunction. Compare the thickness here with the thickness here. So mitral annular disjunction is defined as detachment of mitral annulus from the ventricular wall, producing a gap ranging between 2 to 10. In other words, the posterior mitral valve leaflet is separated from the left ventricular posterior wall, which could be partial separation or circumferential separation. What is the importance of this sign? It is considered as non-invasive marker of sudden cardiac death or a risk marker for malignant arrhythmias. So we use mitral annular disjunction for risk stratification of patients with mitral valve prolapse. And here a very nice comparison between the normal LV posterior wall during systole versus the LV posterior wall in patients with MAD. What about mitral regurgitation? By color Doppler, you can appreciate the presence of mild mitral regurgitation, just mild mitral regurgitation. The aortic diameter was 2.7, the left atrial dimension was upper normal, 4 centimeter. This is a parasternal short axis view at the level of mitral valve. You can appreciate the thickening and the myxomatous degeneration of the mitral valve. And here is a short axis view at the level of papillary muscle. You can notice that the LV cavity looks dilated. And actually, the left ventricular end-diastolic dimension was 6.2 and the end-systolic dimension was 4.1. So we have both dilated LV end-diastolic dimension and end-systolic dimension, and the normal ejection fraction was 61%. This is the apical four-chamber view, and also you can notice the mitral annular disjunction here. This is the mitral annular disjunction, and a very important message, please don't diagnose mitral valve prolapse from apical four-chamber view or apical two-chamber view. The saddle-shaped mitral annulus gives you a false impression about mitral valve prolapse in these two views. So to diagnose mitral valve prolapse, you should look for the posterior displacement of the mitral leaflets behind the level of annulus in either parasternal long axis or apical three-chamber view. By color, there is evidence also of mild mitral regurgitation. And this is another important message here, is to assess the severity of mitral regurgitation in patients with mitral valve prolapse. using the volumetric method. As you know, mitral valve prolapse result in late systolic mitral regurgitation. If we use the classic ways for estimation of severity of mitral regurgitation, it will result in overestimation of the actual severity of the mitral regurgitation. Here we can notice that the mitral regurgitation is only late systolic. So we have to respect this when calculating the regurgitation severity in this case. So the most accurate parameter in this case will be the regurgitation volume. The regurgitation volume here was just 11 milli, which is suggestive of just mild mitral regurgitation below 30 millimeter. Another finding in this patient was the Bickel-Hop sign. How to assess for Bickel-Hop sign? You should obtain a tissue Doppler imaging over the lateral mitral annulus and calculate the S-wave velocity. Bickel-Hop sign is diagnosed when you have a S-wave velocity over the lateral mitral annulus more than 16 centimeter per second, and here it was 24.3 centimeter per second. So this is called Bickel-Hop sign, and this is another method for assessment of arrhythmogenic risk in patients with mitral valve prolapse. This is the Bickel-Hop sign, non-invasive marker of sudden cardiac death. So to summarize, always check for mitral annular disjunction and the Bickel-Hop sign with mitral valve prolapse. Both are thought to be non-invasive markers of sudden cardiac death in patients with mitral valve prolapse. Mitral annular disjunction is defined as detachment of the mitral annulus from the ventricular myocardium, producing a gap ranging between 2 to 10 millimeter during systole. Mitral annular disjunction predisposes for arrhythmias. So you should ask for Holter monitoring in these patients, and you can confirm the diagnosis of MAD, mitral annular disjunction, using the cardiac MRI, which you can tell you the circumferential width of this disjunction, whether it is partial or complete disjunction. You can't assess this using echocardiography. And cardiac MRI will assess the degree of fibrosis using the late gadolinium enhancement as well. Bickel-Hop sign is defined as a high velocity mid-systolic spike in the tissue Doppler imaging of the lateral mitral annulus, and usually it exceeds 16 centimeter per second. Back to our case, what is the explanation of the chest pain? Now we have a 32-year-old man, smoker, and presents with atypical chest pain, continuous chest pain. We should find an explanation for this complaint. My differential diagnosis was, number one, mitral valve prolapse. More likely, it's common that mitral valve prolapse results in this atypical chest pain. But this is not the only possibility. You have another possibility, which is coronary artery disease, which is less likely here because of the atypical nature of the pain. But we have evidence of pathological Q waves, very clear pathological Q waves. We don't have a clear explanation for these Q waves. And we have risk factors as well. He was a smoker, and the labs showed evidence of prediabetes. The third explanation was myocarditis. We have unexplained left ventricular dilatation. In presence of just mild mitral regurgitation, these dimensions are not expected. So it could be a form of myocarditis which can explain the pain and the left ventricular dilatation. The next step, number one, to rule out coronary artery disease, screening for the classic risk factors in the labs, including dyslipidemia as well, and multi-slice CT coronary angiography to rule out the possibility of coronary artery disease, and risk assessment for arrhythmogenic mitral valve prolapse using the cardiac MRI and Holter. Cardiac MRI will confirm the diagnosis of MAD and will assess the severity of mitral regurgitation, and it will help to rule out myocarditis as well. The labs were normal. LDL cholesterol was 120 and hemoglobin A1C was 6% with fasting blood sugar 104. So it was suggestive of pre-diabetes, as we said. What about the Holter? The Holter showed evidence of normal sinus rhythm with infrequent BVCs and no evidence of either sustained or non-sustained VT. Multi-slice CT coronary angiography showed evidence of normal coronaries. What about cardiac MRI? The result of cardiac MRI was as follows. Primary mild to moderate secondary mitral regurgitation due to bileaflet prolapse. It confirmed the findings that were shown in echocardiography. Dilated LV dimension with normal wall thickness and normal systolic function. Infralateral mitral annular disjunction more than 5 mm with characteristic late gadolinium enhancement in the basal infralateral wall with no evidence of infiltrative heart disease, active myocarditis, or ischemic heart disease. So someone may ask me now, what about the dilated LV dimension? What is the possible explanation in presence of just mild mitral regurgitation and the absence of myocarditis? When I reviewed the literature, I found something called mitral valve prolapse associated cardiomyopathy. And the cardiomyopathy in this case is explained by the fibrosis in the left ventricular myocardium, which can result in LV dilatation with subsequent LV systolic dysfunction, regardless the severity of mitral regurgitation. How this patient was treated? I gave him beta blocker and ramipril. Beta blocker to control the pain resulted from the mitral valve prolapse, and ramipril to decrease the progressive left ventricular dilatation. Rapid view of literature, mitral valve prolapse is a common valvular problem that affects up to 3% of the general population. So we are talking about a common problem. It is clearly established that patients with mitral valve prolapse without mitral regurgitation as a group have a normal life expectancy, while patients with mitral valve prolapse, flail leaflet, and significant mitral regurgitation were noted to have twice the sudden cardiac death risk as the general population. Now we have a new terminology in the literature called arrhythmogenic mitral valve prolapse or arrhythmic mitral valve prolapse. Arrhythmic mitral valve prolapse is defined per guidelines as a combination of mitral valve prolapse with or without MAD, with frequent and or complex ventricular arrhythmias in absence of any other well-defined arrhythmic substrate, and regardless the severity of mitral regurgitation. We have two phenotypes for this arrhythmogenic mitral valve prolapse. The first one is arrhythmic mitral valve prolapse due to severe mitral regurgitation. So when you have a mitral valve prolapse with severe mitral regurgitation, this is the first category of arrhythmic mitral valve prolapse, irrespective of the valvular morphology. And patients with these features showed high risk of excess mortality, including excess sudden cardiac death risk compared to the general population. The second phenotype is arrhythmic mitral valve prolapse with severe myxomatous disease. What is the meaning of severe myxomatous disease? Marked redundancy with excess leaflet length or excess thickness, as well as MAD, irrespective of the mitral regurgitation severity, and these type of patients are prone to develop arrhythmia over time. What about the workup? In this type of patients, we should ask for echo, ECG, Holter, and cardiac MRI. Mitral aneurysm disjunction is frequent at mitral valve prolapse diagnosis, and it is associated with ventricular arrhythmia occurrence, but doesn't have excess mortality within the first years of diagnosis. But you should notice that ventricular arrhythmia development in mitral valve prolapse is progressive over time. So repeated arrhythmia monitoring is required for arrhythmic mitral valve prolapse phenotypes without severe ventricular arrhythmias at index monitoring. This is a very nice algorithm for risk stratification of patients with mitral valve prolapse. And this is very recent approach. Patients with mitral valve prolapse are classified into 4 categories upon presentation. The last category is aborted cardiac arrest. If we have a patient with mitral valve prolapse resuscitated from cardiac arrest, then the next step will be ICD implantation. And if we have a frequent ventricular tachycardia during the follow-up period, we can ask for ablation or antiarrhythmic drugs. The other 3 presentations include either asymptomatic or palpitation or unexplained syncope or pre-syncope. The next step in these 3 scenarios will be Holter monitoring. And we have one of 2 possibilities. Either there is evidence of ventricular tachycardia or there is no evidence of ventricular tachycardia. If there is evidence of ventricular tachycardia, the second step will be looking for the high-risk ventricular tachycardia. What is meant by high-risk ventricular tachycardia? Number 1, sustained ventricular tachycardia or polymorphic non-sustained or fast non-sustained or ventricular tachycardia either sustained or non-sustained associated with syncope. If there is evidence of high-risk ventricular tachycardia, the next step will be checking the severity of mitral regurgitation. If there is evidence of severe mitral regurgitation, the management will be mitral valve repair plus or minus ICD implantation. If there is no evidence of severe mitral regurgitation, so the next step will be ICD implantation. And don't forget to check the phenotypic risk features. What is meant by the phenotypic risk features? Number 1, in ECG, T-wave inversion in the inferior leads. Holter, multiple polymorphic BVCs. Echo, mitral annular disjunction with redundant leaflets and enlarged left atrium, and ejection fraction 50% or less. Cardiac MRI, late gadolinium enhancement. The possibilities, either we don't have any of these phenotypic risk features, then the decision will be just follow-up. If we have few from these high-risk features, we will ask for frequent monitoring. If we have multiple of these phenotypic risk features or syncope, we will ask for implantable loop recorder. If the implantable loop recorder showed high evidence of high-risk VT, we will continue in the algorithm as we said we should check the severity of mitral regurgitation, and we have severe, if we have evidence of severe mitral regurgitation, we should refer the patient for mitral valve repair plus or minus ICD. If there is no evidence of severe mitral regurgitation, refer the patient for ICD implantation. I will finalize this lecture with this very important slide, which summarizes the ECG findings in patients with mitral valve prolapse. Number one, T-wave alteration. The most common finding in patients with mitral valve prolapse is flattening and inversion of the T-waves in the inferior leads, with or without ST segment depression. The second abnormality is ST segment abnormalities. In patients with mitral valve prolapse, ST segment depression may be observed, which may accompany negative T-wave in inferior leads. In addition, horizontal ST segment depression may occur during exercise in patients with mitral valve prolapse and normal coronaries. So it can result in false positive result. The third finding is pathological Q waves, similar to our case. Pathological Q waves have been described in some patients with mitral valve prolapse, simulating inferior or anterior myocardial infarction together with normal coronaries. And the last finding is arrhythmia. Ventricular and supraventricular tachyarrhythmias are common in patients with mitral valve prolapse and may occasionally lead to sudden cardiac death. Premature ventricular complexes, BVCs, are the most common arrhythmia in patients with mitral valve prolapse, and it is observed in about 1/3 of patients. Thank you so much.
Thank you so much, Dr. Ahmed Mohsen. Although I'm an interventionalist, I'm not a very smart imager like you and Dr. Ahmed Farid, but I enjoyed this so much. And I know that mitral annular disjunction is one of the most uprising topics and interesting for research because actually of the cases that are found on the cardiac MRI with low gadolinium enhancement that's not explained by ischemia or other arrhythmogenic causes and the association with sudden cardiac death.